Hello, good afternoon. My name is Rihan and I will be presenting case study on UTI today. Shari is a 35-year-old female complaining of possible signs of UTI and complicated UTI. A brief overview of her chief complaint reveals that she experiences discomfort when waiting for past 14 days. Nonetheless, she complains of recurrent pain above the pubic bone while previously being diagnosed with type 2 diabetes. The severity of pain is quite high as she finds it challenging to undertake daily living activities. She also noted previous cases of recurrent UTI with the review of system, confirming various symptoms including fever, thirst, and night sweats. Based on patient's medical history, she was diagnosed with type 2 diabetes 5 years ago and is currently on metformin. She's also using lisinopril to control her hypertension, but avoids any pharmaceutical products in addressing the recurrent UTI. Similarly, Sherry lives with a roommate in one-bedroom apartment and occasionally visits her partner during the weekends. She denies any substance use, considering the nature of her work and need for continuous drug tests. Apart from this, her mother lives with diabetes and hypertension, while her father has a history of obesity and kidney disease. The objective analysis indicates that the patient has high fever complemented by high heart rate at 92. Furthermore, her respiration rate is set at 24, which is elevated from the normal resting range with an oxygen saturation of 93. The tenderness in the suprapubic area confirms discomfort, while the discharge and inflammation shows the presence of an UTI. The leukocytes in her urine also show that her body is fending off the infection and bacteria. Apart from this, her blood sugar is set at 126, which aligns with type 2 diabetes signs and symptoms. As such, the working diagnosis focuses on presence of dysuria, although other conditions like PVD and vaginitis will be considered in treatment planning. The patient's situation necessitates a multi-pronged approach that entails the use of medicine like ciprofloxacin. This medicine will be administered orally for 7 days while monitoring the symptoms to determine its efficacy. Likewise, the patient will take acetaminophen to manage her fever, while metformin addresses her diabetic needs. Frequent hydration is revised for diluting the contaminated bacteria and streamlining voiding. Effective elimination will further prevent bacterial proliferation, with the patient also avoiding any diet that exacerbates the issue. Therefore, they must check with the PCP, who will conduct subjective and objective assessment. The IDSA classifies a complicated UTI as a common disease that occurs in people with underlying condition, thus making it challenging to treat while increasing the likelihood of infection. The guideline has been updated in response to new findings showing that females like Shari are more susceptible to exposures. On one hand, the gender urinary tract is predisposed to proximal spread following bacterial seeding. The natural exacerbation, the frequency of infection, and leads to a wide range of symptoms. For instance, the patient reports fever, which serves as a natural defense mechanism, whereby the body increases its temperature to fight off bacteria. In some cases, the bacteria causes pyelonephritis, and it moves from the lower urinary tract to kidney, signifying progression. Likewise, further denotes that the progression contributes to CVA tenderness as it causes inflammation and swelling in the kidney and surrounding structures. This signifies a serious condition, with some patients also noting both flank and suprapubic pain. Prior to developing a diagnosis, PCP are required to consider the likely cause of dysuria and UTI. Indicate that the causal factor are delineated into two forms, including infectious and non-infectious. With the former, E. coli is a pock marker as a leading variable as it leads to UTIs and bladder kidney infections. Nonetheless, gonorrhea and Gentilium-related bacteria are linked intermittently with increased risk of exposure and complications as well. Following determination of the cause, the PCP then moves towards examining urine samples for signs of infection by focusing on bacterial presence and the white blood cell or red blood cell count if an infection is suspected. The IDSA recommends performing a urine culture to highlight the particular bacteria and also inform treatment planning. STI and pregnancy tests also come in handy in narrowing the scope of focus, while cervical smear assesses the presence of vaginitis. It also is important for doctors to complete ultrasound that will offer images on structural problem, with cytoscopies determining the damage caused by recurrent UTIs. Thus far, empiric therapy has emerged as the best fit approach to manage CUTIs and dysuria. Per IDAS, each decision must consider the key pathogen before moving towards this severity, source, and patient-specific factor. Nonetheless, the patient's history is useful in gauging their response to treatment and allocating the right medicine to alleviate antibiotic resistance. By reviewing the AST pattern, the decision and refine based on the profile and identity with the aim of targeting the specific bacteria. The guidelines recommend using cephalosporin, which are classified as beta-lactamase antibiotic, helping address the key pathogens. These drugs inhibit the synthesis of bacterial cell wall by targeting and underlining proteins. Likewise, piperacillin tazobactam kills the bacteria related to fluoroquinolone, tasked with managing the proliferation of both gram-positive and gram-negative bacteria. When administering treatment, professionals must identify each patient and define the severity of illness. They then determine the presence of sepsis before evaluating the key variables that impacts outcome. Alternatively, the PCP can consider using trimethoprim sulfamethoxazole, approved for treating UTIs, especially in females. The drug is administered orally without considering meals, with oral dose being set at 160 milligrams for trimethoprim and 800 milligrams for sulfamethoxazole. However, it must only be used if the resistance level are below the threshold. Throughout the process, the patient must receive education on the possible side effects and importance of complying with key regimen. Overall, Shari's case necessitates a tailored approach that will consider her needs and underlying condition. The PCP will administer third or fourth generation cephalosporin to manage the CUTI. The administration process follows the guideline recommending this drug as the first line option with focus on dose, duration, and education. Constant monitoring is also required, whereby urine culture results are analyzed to ensure success. Finally, the patient will change her diet and engage in safe sex or personal cleanliness with the aim of alleviating further recurrent UTIs. Thank you so much. That brings our presentation to the end. I will be posting questions and hoping for a great discussion. Have a great evening.